All right, colleagues, welcome. Today, we're going to distill the key principles for managing trochanteric fractures. The goal here is simple, to focus on actionable strategies you can take right into the OR to elevate your practice and, most importantly, improve your patient outcomes.
So let's start with a case we've all seen, right? A real challenge, the unstable trochanteric fracture that creeps down into the subtrochanteric region. This is the kind of pattern that really tests our skills. It demands meticulous planning before you even step into the theater and absolutely precise execution once you're there.
Okay, so here's how we're going to break this down. We'll start with the core operative principles. Then we'll boil those down into a super practical checklist you can use intra-op. After that, we'll quickly look at the key evidence behind these techniques, and we'll wrap up with the powerful idea of a personal audit loop.
All right, let's dive right in. This first section is all about the fundamentals that really dictate your success, starting from the second you look at those initial x-rays. We're talking planning, reduction, and fixation.
Look, the absolute first rule is this. You have to recognize instability. Why? It's simple. In these fractures, the bone itself can't share the load. That means every bit of stress from weight bearing goes directly through your implant. This makes your choice of hardware and, frankly, the quality of your fixation absolutely mission critical.
So take a look at these. These are the two classic unstable patterns you've got to burn into your brain. On the left, you've got your reverse obliquity fracture, and on the right, the trans-trochanteric pattern. The big takeaway for both of these? They lack a competent lateral buttress. That's a huge deal.
And here are two more major red flags for instability. On the left, you see that significant posteromedial comminution. That means you've lost that critical calcar buttress. And on the right, any kind of subtrochanter extension. Seeing any of these four patterns before you operate should immediately get you thinking about an intramedullary device.
Now, before a single piece of metal goes in, your entire goal is to restore that medial cortical contact. Why? Because losing that medial support is one of the single biggest predictors of mechanical failure and implant cutout, period.
And hey, don't be a hero trying to get that reduction. Use every tool in your toolbox. Percutaneous clamps, joysticks, even some temporary K-wires. These things are essential for getting control of the fragments and holding that reduction, all without having to do a massive soft tissue stripping.
This is the image you never want to see post-op. This is a very small reduction. The telltale sign is when the center of the femoral head drops below the level of the tip of the greater trochanter. This deformity basically makes the femoral neck longer, which cranks up the lever arm on your fixation and just skyrockets the risk of failure. So how do we know if our fixation is actually any good? We need a number, right? We need to measure it. And that's where the tip apex distance, or TAD, comes in. It is truly a cornerstone of modern hip fracture surgery.
And here it is, visualized perfectly in the diagram from Baumgartner's original paper back in '95. It's just the sum of the distance from your screw tip to the apex of the femoral head, measured on true AP and lateral views. This is a critical measurement. We should all be calculating and documenting for every single case.
So what's the magic number? Well, the evidence is pretty clear. Your tip apex distance has got to be less than or equal to 25 millimeters. Hitting that target has been shown over and over to dramatically reduce the risk of lag screw cutout. To be honest, most of us who do a lot of trauma will aim for even less than 20.
Now this radiograph is what you're aiming for. This is the money shot. The lag screw is sitting nicely in that central inferior quadrant on the AP, and it's dead center on the lateral. That's the position that gives you the best purchase in the femoral head and lets you nail that ideal tip apex distance.
Okay, this next part is something I want you to repeat to yourself in the OR. It's a simple rule, a mantra even, that everyone should have committed to memory. No lateral wall, no hip screw. This is absolutely critical, especially for those reverse obliquity and trans-trochanteric patterns we just talked about.
And if you ever wondered why that rule is so important, look at this. On the left, you've got the reverse obliquity fracture. On the right, you see what happens when you treat it with a sliding hip screw. Without that lateral buttress to push against, the shaft just medializes, the proximal fragment goes lateral, and you get, well, catastrophic failure. One series actually reported a mind-blowing 56% failure rate with this exact mismatch. All right, for those of you using a nail, and that's most of us for these fractures, here are a few technical pearls you absolutely have to know. First, your start point. Go slightly medial to the trochanteric tip to avoid creating varus. Second, reduce the fracture before you ream. You don't want to create more comminution. Next, Always be thinking about that anterior bow of the femur so you don't perforate distally. And finally, this one's huge. Release traction before you put in the distal locks. You do not want to fix the fracture while it's distracted. And look, let's be clear. Our job isn't done when the dressings are on. To really move the needle on outcomes, we have to embrace orthogeriatric co-management and make sure every single one of these patients gets into a secondary prevention pathway for their osteoporosis. That's how we prevent the next fracture. Okay, so that was a lot of principles. How do we make this really practical in the heat of the moment? Well, let's distill it all down into a rapid, actionable checklist. Think of it as a cognitive aid to make sure you hit every key point on every case.
So here it is. 1. Have I confirmed the fracture type and stability? 2. Is my reduction good? Is the medial calcaire restored with no varus? 3. Did I pick the right implant for this pattern? 4. Is my fixation solid with a tad under 25? 5. Is that lateral wall intact and protected? And 6. Are my final fluoro views perfect, true AP and lateral? Trust me, this simple check can prevent a world of hurt.
So where does all this come from? Let's talk about the evidence that underpins these principles. For any trainees listening, or really anyone who wants to do a deeper dive, this is your essential reading list. First, you've got to start with Baumgartner's original paper on TAD. It's just foundational. For a really modern take, the recent Schmidt's trial in JAMA is crucial for understanding the whole nail versus screw debate. Tarrant's work really drives home the importance of the medial calcar. And if you deal with a lot of poor quality bone, Rompen's meta-analysis on cement augmentation is an absolute must-read. All right, let's bring it all home. How do we take all this information and use it to create a real cycle of continuous improvement in our own practice? And that brings me to my final and maybe the most important point. And it's really a question for you to take back to your own practice. Are you systematically and honestly auditing your own complications? Are you recording those key quality metrics like TAD and reduction quality? Because at the end of the day, having great hands and mastering surgical technique is obviously essential. It's the foundation of what we do. But it's the process of creating a personal audit loop, of systematically learning from our complications. That's what really truly drives us from just being proficient to achieving excellence.